Okay. Now that we've talked about chest, and we've also talked that everything from basically my fourth or fifth intercostal space, right, to my belly button is considered both abdominal and trauma. Let's talk about the abdomen. Several different borders. So when we start talking about cavities, we're really talking about thoracic cavity or chest cavity, abdominal cavity. So it's kind of important to know kind of where they split, right? Where one is where it becomes the pelvic cavity or the pelvis versus abdominal. So superior border, which we know superior means up or above, right, is the diaphragm. The inferior border is the pelvis. Okay. Posterior, back side, which would be my lumbar spine, and then the anterior border would be the muscular abdominal wall. So when we talk about the abdominal cavity, we're not talking about the ab muscles at all. Okay, it's basically kind of in between the spine and the inside of the musculature. Okay. Injury and illness are very difficult to assess in the abdomen because there's just so much structure in there. It's huge. The amount of stuff that you have in your gut is significant. Okay. So it's divided. Tell me, how many hunters do I have in here? How many rifle hunters? Okay. So here's kind of what you want to think about it. If you would put your crosshairs right on the umbilicus or right on the belly button, that's going to divide it into those 4 quadrants, right? Because you have crosshairs, so you get a right upper, a left upper, a right lower, and a left lower. Okay? So kind of go straight up and down through the belly button and then right across through the belly button. All right? And that's generally how you discuss kind of what or diagnose or start to make those good suspicion of index of suspicion based on what part of the abdomen we're talking about. Okay. Major structures, the esophagus, of course, right? You guys remember what the esophagus is. Then you got your liver, gallbladder. Can you guys see that gallbladder? Here it is, tucked right up kind of underneath or behind that liver on the right side. Okay. And then your pancreas kind of goes predominantly on the left side, but a little bit on the right.
Is that in front of or behind the stomach?
It's kind of behind. Yeah, they just kind of highlight it that way. See, there's the lines for the stomach. Yeah, so that you can see through it. And then here's the stomach. Large intestine kind of hits every single quadrant. So does the small intestine. And then here's the appendix. How many of you guys have ever had your appendix removed? None? That little booger causes a lot of people a lot of problems. Okay? So, 4 quadrants. This you have to know. Okay? So, in the right upper quadrant, you got the liver, right kidney, colon, pancreas, gallbladder. In the left upper, you've got spleen, some part of the liver. Okay? Kidney, stomach, colon, pancreas. Left lower, kidney, colon, small intestine. Major arteries to the vein and legs. Do you see them? Okay? And then in the midline area, so what's going to continue to run down the middle of my abdomen is going to be things like my aorta, which is important. Pancreas kind of sets midline significantly. Right there. Okay? Small intestines and my bladder, my urinary bladder. Okay? And then in the right lower, right kidney, colon, small intestine, major arteries and veins, again, ureter, and then the appendix. Okay. Again, right upper quadrant. What of these is a solid organ?
The liver.
Okay.
Kidney.
Okay. It's not hollow. So when we start talking about intestine, they're like a tube, right? So is your bladder. Your bladder is like a tube. It's like it's just that, a bladder. I don't know how else to. So it basically is it something that's empty and it's meant to hold
Like a bag.
stuff like,
Plastic bag.
yeah. So your bladder is meant to hold urine. Your stomach and your intestines is meant to hold food and waste kind of stuff. Okay? Left upper quadrant. Spleen, is that solid or hollow?
Solid.
Solid. Stomach?
Hollow.
Pancreas?
Solid.
Kidney? Okay. Part of the liver? Very solid. Colons? Hollow. Okay. You know the difference between the transverse and descending? Transverse is going kind of horizontal across. Descending obviously is going down. Right lower, ascending colon, appendix, right ovary, and then the right fallopian tubes. And this is, of course, only females. Okay, have an ovary and a fallopian tube. Okay. Left lower quadrant, again, the colon, the left ovary, and the left fallopian tubes. Huh? The end of the colon, kind of like what's going into the rectum. Okay. Periumbilical area located around the navel. Small bowel lines, all four quadrants. We kind of already talked about that. And then suprapubic area is located just above the pubic bone. That's where your bladder and in females the uterus sit, both midline, down right above that pubic bone. Okay, very low. All right, perineum. So this is the abdominal cavity lining, and this is kind of hard to see, right? You see that? Peritoneal cavity. Okay, it's divided into two spaces: the peritoneal and then the peritoneal cavity, and then the retroperitoneal space. Okay, so retro would mean what? Right, or behind. So it's behind the peritoneal cavity. So in the peritoneal cavity, you're going to have things like your spleen, liver, stomach, gallbladder, bowels. Okay, in the retroperitoneal, right? So remember, your pancreas sits behind your stomach, so it sits kind of in that retroperitoneal space. Okay, kidney, ureter, inferior vena cava kind of sits in the retroperitoneal area. Abdominal aorta, urinary bladder. Remember, it sits real low. Okay, and then reproductive organs also. Injuries to the retroperitoneal areas often cause back pain. Okay, so if you have a kidney, if you have damage to a kidney, you're usually going to have flank pain or pain right here in your back. Okay. So now this is kind of a cut. Okay, so they've kind of taken out some things like spleen, liver, stomach, intestines. So now we're looking beyond that into that retroperitoneal cavity. You see the difference? So it's layers. Okay. So here's your inferior vena cava. Your duodenum basically connects the stomach to intestine. Kidneys, kind of hard to see because it looks like it's wrapped little sausages. You see those? Okay. And then the ureters, pancreas, there's your aorta, and your sigmoid colon. Okay. We kind of talked a little bit about this already. Organs can be classified as either hollow, solid, or basically major vessels, right? What are my major vessels? Aorta and inferior vena cava are the big ones. Okay, when we're talking about abdominal, right? Because remember, my superior vena cava is up in my thoracic cavity, and it doesn't come down; it attaches at the heart. Solid organs are liver, spleen, kidneys, and pancreas. When a solid organ is injured, they usually bleed heavily and cause shock. Okay, they're vascular and they're full, right? Not full of contents. So we need to kind of be thinking, if my patient is showing signs of shock, I need to be thinking probably one of these things is injured if they have abdominal injuries. Okay, because the stomach won't cause shock right away. So if I have a rupture in my stomach, okay, doesn't necessarily cause shock right away. Can, but not like these do. Okay. Solid organs. Liver is the largest abdominal organ. It is the most frequently injured. Okay. Fractures of ribs 8 through 12 on the right side, and bleeding can be a couple of things. Okay. So bleeding can be either into the freely into the cavity, or it can kind of be encapsulated. Okay, and then it's a slower bleed because there's more pressure. It doesn't bleed kind of as free flowing. Okay, so am I bleeding kind of into my liver, or did I split my liver in half, so to speak? Okay, those are exaggerations, but you understand what I'm saying, right? Maybe. Okay. Your gallbladder is kind of tucked back here. There's your common bile duct. There's your portal vein and your hepatic artery. And then your hepatic vein. Okay, spleen. This is frequently injured with trauma at ribs 9 through 11 on the left side. Now, keep in mind, children are different. Okay, and we'll learn a little bit more about children later, but remember, their rib cage is more horizontal. It doesn't kind of go at that angle, so it doesn't generally come down and kind of protect as much. Okay? This bleeds easily. The capsule around it kind of tends to slow the bleeding. Okay? In development shock, rapid shock onset is when the capsule itself ruptures. So when you start talking about capsule, think splitting it in half versus it just tears on the inside. Okay?
Do we need to know the names of the arteries and stuff that are being...
I want you to be familiar with it. I don't think it'll probably be on a test. Okay? But it's important to know that, right? Because, see, you've got veins and arteries that invade all of these. Okay? And so, if I rupture a vein, it's not going to bleed like if I rupture an artery. Okay? So knowing that they're vascular in nature can make a difference. Solid organ, the pancreas, it lies across the lumbar spine. Here you go. Okay. Sudden deceleration produces straddle injuries onto the spine. Okay. Very little hemorrhage. Leakage of enzymes, though, it causes problems in that retroperitoneal space. It can cause volume loss. These are the guys who get irritation. So remember, anything that's not meant to be, for example, blood. When I bleed into my abdominal area, that is very bad. Okay, the blood is not well tolerated anywhere but inside the vascular. Well, it's the same thing with these enzymes here. Okay. Hollow organs are stomach, gallbladder, large intestines, uterus, and then the urinary bladder. Rupture of these, basically, ma'am.
Oh, what are the urine? Oh, what are they?
Carry urine. Okay. So rupture of these, basically the problem with these, they're not quite as vascular, right? I mean, don't get me wrong, of course they've got blood flow. But the bigger problem is, suppose I tear my small intestine. I have a tear in my intestine. What happens to all that wastage, all that nasty stuff? Where does it go? It goes not. It just goes into that peritoneal area, right? Causing infection, causing peritonitis, causing some of those other problems. So the problem with those is they're very dirty.
Is there a disease that eats away at your and stuff like that? I can't remember what it's called. It's common. Not Bill. Huh?
Taco Bell. Oh my. Okay, so for example, okay, if you have urine, if you rupture your bladder and you have urine that spills into your abdominal cavity, that's acidic waste that's just sitting in there. Okay? Hollow organs. Stomach, obviously, it holds acid and enzymes. This causes immediate peritonitis, right? Because of that acid, kind of causes a lot of irritation and complications for that peritoneal lining. Okay? Pain, tenderness, guarding, and rigidity. You have the pyloric sphincter here, and then you have the lower esophageal sphincter here. So it comes from the esophagus. Fundus basically is the top point. So when we start talking about OB, we'll talk about the uterine fundus. Okay? That's just the top part of the uterus. Okay?
We talking about Crohn's disease?
Yeah.
No, it's not. It doesn't.
Crohn's is a
different.
absorption and stuff.
Maybe that's what it's called. Yeah.
'Cause you said common, it's pretty common.
Not common, but
Well, it's pretty,
I mean,
a lot of people
it's
have
not like it's millions of one or
It doesn't-
something.
I bet you that's not what you're thinking of, though. I don't think he's probably not thinking of
I
Crohn's.
think I am.
Really?
The one down
That's
there,
why
like-
he said
like-
that. I didn't think there's nothing really common about like
Yeah,
eating
like,
later.
especially women like just secreting everywhere. Just I don't know. I was told about it. It sounded terrible, and the fact that it's not like a uncommon kind of disease.
Okay.
Isn't Crohn's like IBS? I mean, it's like
It's kind of it
always
affects the
like
colon
an
and it causes bleeding, and Crohn's
Yeah.
disease people will have to have blood transfusions because they have significant rectal bleeding. Anyway,
Correct. That's
okay, hollow organs. So the colon, right? The colon has okay. How many of you guys have taken antibiotics? And what's one of the complications with antibiotics? It may give you diarrhea. Right? Because we have a normal flora or a normal bacteria that grows like in places like our colon. Okay? So when you take antibiotics, it knocks out that bacteria because that's what antibiotics do, right? That's what causes you to get diarrhea. Which is why they now sometimes put people on, what are they called? Anyway, the flora medicine to keep the bacteria in your colon so that you don't have those problems.
Probiotic.
Thank you. Absolutely. Probiotics. Okay? So we realize that your body needs some bacteria, and it needs it in places like the colon because think about the nasty stuff that comes through there. It's kind of got to regulate things, so to speak. Okay? So when you have an issue or rupture in your colon, you have that spillage of the bacteria that's good in my colon but bad everywhere else. Okay? May take 6 hours to develop peritonitis. So it doesn't act quite like the stomach acid does. Of course. It takes a little while for bacteria to grow and flourish. He's making... Your faces are classic shaper. Okay? And then the small bowel has fewer bacteria. It may take 24 to 48 hours to develop, but generally it develops. So they have to go in there and kind of literally clean these people out. Okay? Major vascular structures, aorta, inferior vena cava, and then the major branches as you kind of get down here. Now those are problematic when you start talking about pelvic injuries, right? When you start talking about pelvic injuries, think about your aorta splits and travels right through your pelvis to go down to feed both your legs. Okay? Injuries, of course, can cause severe exsanguination, which means basically bleeding out. And it doesn't take very long to bleed out once you damage one of these major structures. Okay? Abdominal trauma. Most survive to reach the hospital. Okay? This is that 1 to 3 hour time frame. This is going to depend on my index of suspicion, how I relay my patient, even the care that I provide them prior to getting to the hospital. Okay? Common factors leading to death are failure to adequately evaluate, delayed resuscitation, and that starts with us. Guys, when we talk about resuscitation, I know most generally you're thinking cardiac CPR type resuscitation. When we talk about resuscitation, they're talking about anything from airway, breathing, circulation. So it may be IV fluids to resuscitate somebody who's got low volume. Okay? So this doesn't necessarily mean that they die resuscitation. This means trying to resuscitate the problems that they're having. Okay? Inadequate volume, inadequate diagnosis, and delay to surgery. So let me share something with you. If you think you don't have an impact on what happens once you get to the hospital, you are sadly mistaken. Okay? So prime example, and I did this as kind of a treat. It's kind of a, let's see how it goes. So we have joint training, Temple Fire Rescue, Scott and White EMS, and we have both paramedics and EMTs. Okay? And so here's what I said. Let's give our EMTs the opportunity to work through their scope of practice. Let's give them the opportunity to get some hands-on, right? Because it's too often that paramedics kind of tend to take over and the EMTs kind of tend to stand back and go, what do you need me to get? What can I help you with? Okay? Which is a very important job. You don't feel very important at the time, but it is a very important job. So what we did is, I said, okay, I gave them an allergic reaction of a patient who has a history of asthma. They present very similar. Okay? And we'll learn about differences later on. They present very similar. And so the EMTs we sent in, and we made the paramedics stand outside. So we made the EMTs work it to their ability. So they had to do their assessment, started the treatments they could start, medications they could start, etc. The EMTs who picked up that it was an allergic reaction were able to alert their paramedics, and they had a much better success and survival rate. The EMTs that presented that thought this is asthma, when they presented it to their paramedic that way, it took their paramedic a whole lot longer to catch on that it was something other than asthma. The same thing happens when you go to the hospital. So if you don't have that high index of suspicion that you pass on, remember, we are the key to them getting the information they need, especially when it comes to trauma and the things that we see on a scene. Damage to the car, intrusion into the passenger compartment. You know, does it look like they hit the steering wheel, the mirror, right? Those kind of things. It's important that we have a high index of suspicion that we not only have it, but we relay it appropriately. Okay? That's what they're talking about here that causes significant problems when it comes to people with abdominal injuries. This is a huge problem if we don't do what we need to do to relay that. Okay? Because it does really have a profound effect on our patients in the end. All right? What does it take to have a high index of suspicion? Of course, the mechanism. Trauma to the lower chest, back, flank, buttocks, perineum, anything kind of like that, right? It's not uncommon for people to get into a knife fight, and they kind of come at them, and they try to kind of hold their arm or move their arm. It's not uncommon for them to get hit in the flank or in the side and not even realize that it happened initially, okay? Hypovolemic shock with no readily identifiable cause. So if you're kind of going, something here doesn't fit. Something doesn't fit. My patient is tachypnic, they're tachycardic, their skin is showing me some signs of shock. And what are my early signs of shock? Cool, clammy, right? Maybe not. They may not even have too much of a delayed cap refill initially. Those are the things that even before their blood pressure starts to fall, I need to go, something's not right. Heart's intact, lungs are intact, we're good there. I'm not thinking head injury. I'm missing something in the belly. The belly does a very good job of hiding it. Okay? It's harder to find it. Okay? Diffuse sleep, tender abdomen, anytime they kind of go, my belly hurts, and you go, where does it hurt? And they go, oh my God, it hurt everywhere. Following a trauma, you need to be thinking, high index of suspicion, they have a significant injury somewhere. Okay? And then pain in an uninjured shoulder. This is called Kerr's sign. Okay, and this is referred pain, usually from irritation of the diaphragm. Spleen, for example, Kerr's sign is right shoulder pain secondary to a splenic injury. And that may be their only complaint. No, my shoulder hurts. K-E-R, K-E-H-R. I don't remember. I'll have to look it up. Referred pain, it goes through the diaphragm and it works on those the nerve tracts.
So it's a nerve that goes,
it wraps around. So everything wraps from my back around, right? And it wraps around, it kind of comes down a little bit. You guys remember? Okay? Any irritation of the diaphragm. I once had a nurse tell me he's got hiccups and he's got chest pain. He's having an inferior MI. Sure enough, he was right, because it was irritating the diaphragm, which is what was causing his hiccups. Okay? So look for signs of injury, discoloration. And remember, redness comes before bruising. Okay? Oftentimes, we're first on scene, so they may not have that bruising initially, but we do need to document and note the redness, and we need to pass that along, right? Plus, colors change as they progress. Okay, so depending on my transport time, I may see the bruise, I may not see the bruise. Okay? Tire marks, obvious open injuries. Assume that any abdominal injury is serious until proven otherwise. People can bleed out from a liver or spleen lac pretty quickly. Okay? That's that golden hour that we get. Okay? Well, that the patient, that's what we're shooting for our patients. Okay, injury above the umbilicus also involves the chest until proven otherwise. All right, remember whenever my diaphragm pulls down, it's much lower than what you might think. All right, unexplained shock. So, assess skin color, temperature, cap refill, and vital signs. Remember, what do I know about blood pressure and shock? Early or late sign? Don't wait for your blood pressure to start showing changes before I start suspecting shock. Okay, I cannot stress that enough. There's a reason they call it compensated, and then it goes to decompensated and irreversible. Okay? Shock findings. We know this, right? Tachycardia, restlessness, cool, moist skin. All right? In trauma, signs of shock suggest abdominal injury if there's no other obvious cause. Period. All right? Signs of injured abdomen. Diffuse tenderness, which we already talked about. Pain. So pain referred to the shoulder. Basically the organ under the diaphragm that's involved, like the spleen. Pain referred to the back, that would be a retroperitoneal. I'm thinking kidney. Anytime they have pain in this flank, there's not much else in the flank, right, other than kidney. Anybody in here ever had a true kidney infection? It hurts, right? And where does it hurt? It hurts in your back. Yeah, and that's one of the things. Did they do that, Paige? Did they set you up and they thumped you right on the back? And you about came off the table. It is painful. Yeah. Yep. Okay.
I do have a question for you real quick.
Okay.
I'm kind of off just a little bit, but how do you go into shock from dehydration? And
because it causes low circulation. Because when you get dehydrated, it's a volume loss. So when you lose your volume, you don't have the ability to perfuse your end organs. Okay. So abdominal pain. What's important? It's not important for me to go. For sure, it's the liver. Before I leave here, it's the liver, right? I need to have a high index of suspicion, but I need to move. Okay. So it's more important to have that high index of suspicion and start suspecting one of those injuries than it is to figure out exactly which injury it is. Okay? Leave that up to the surgeons. So treat your clinical findings and then manage the same regardless of the specific organ injured. Right? Does it matter whether it's my spleen or my intestine? Well, I need to be suspecting shock as far as spleen goes, and I need to be prepared for that. But they both need, what's their definitive treatment? Surgery. Am I going to do anything differently to help them? Absolutely not. Okay. C-spine mechanism indicates, of course, airway. High flow O2 is important. Remember, if we're bleeding, we need the extra oxygen, okay, losing hemoglobin, that kind of stuff. Assist ventilations if needed. Focused or detailed physical exam. Give them nothing by mouth. Oh, but I'm so thirsty. You know what? We're going to get you to the hospital. They're going to give you some fluid in your veins. They're going to help take care of that. But, if I don't want you getting sick to your stomach. Okay? Mask pants may be helpful in slowing an intra-abdominal bleed with shock. Again, you got to think about indications, contraindications, relative contraindications. Okay? And then spinal motion restriction if needed. Remember, with blunt trauma, we're more likely to need spinal motion restriction than in penetrating trauma with no signs of a neurological defect. Okay? Special considerations. Impaled objects. So what do we do if we have an object that's impaled? Everybody know what an impalement is? Right? Object that is in somebody. We leave it in place. We may have to cut it or shorten it for transport. We may have to get creative with how are we going to transport, okay, nonetheless. All right? Evisceration. Evisceration is basically where you have like a laceration, and usually it's the intestine, but not always, protrudes to the outside, to the outer wall, okay? So literally this is intestine. Okay? So what do we...
Sorry. So that can just come out from somebody like slicing the
Yep. Sure can. I know, right? So if something is sticking out, do not put it back in. No matter what it is, I don't care if it's an eyeball, if it's intestine, if it's a baby, okay? If it's umbilical cord, we don't shove things back in. All right? Cover the exposed organs with saline, moisten. Look, use a trauma dressing. Do not use 4x4s. How come? Did you see that mess? What are the chances that you're going to find all those 4x4s? And what happens if you don't? Okay? So make sure you use trauma dressing. Cover the first dressing then with a secondary dry dressing or aluminum foil. And this is basically to kind of keep that moisture. If it's wet, we need to keep it wet. If it's dry, we should keep it dry. Right? Is that simple advanced first aid for you? Yep. Okay. All right. Genitourinary trauma. So this is my urinary system. So here are my kidneys. Here's my ureters. So basically that ureter comes down from the kidney and delivers the urine to the bladder and then the urethra. Okay? Kidney. 50% of all GU trauma is going to involve a kidney. Okay? Here's what you need to know about the kidney. It's rare to have solely kidney involvement. Usually it's associated with other injuries. Okay? So that's kind of like my ribs. If you think about it like that, usually if I have a rib injury, I need to be thinking, okay, what are the injuries do I have underneath there? Same goes with my kidney. Okay? Say again, ma'am? Gunshot wound. So penetrating trauma, often GSW and stab wounds. Okay? So blunt would be a direct blow to the back, flank, or upper abdomen. Anytime that you have, you're suspecting thoracic or lumbar, like lower thoracic or lumbar, spinal injury, or fractures of 10th and 12th rib, you need to be kind of thinking kidney involvement. Okay? Acceleration and deceleration, you can have that shearing of the renal arteries or veins. Again, it's that same thing. It depends on where it's just like the aorta. Where is it secured or anchored? Thank you. Where is it anchored versus where isn't it, and kind of how did that injury go? Okay? Signs and symptoms. Gross hematuria. Do you guys know what hematuria is? Blood in the urine. So frank or gross blood in the urine. They're not talking gross ooh, they're talking lots of it. Okay, so if they're bleeding it, or if they're urinating and it looks more like blood than urine, that is gross hematuria. All right? And that happens in about 80% of the cases. Just because they don't have it doesn't mean that you can rule it out either. And are we going to see that? Maybe, maybe not. Think about the transfer that you're going to get when somebody accidentally took that patient to Cameron, or maybe they had to go there because they needed that pleural decompression or that chest tube. Now you got to go pick them up. Now you notice that they've got gross or frank blood in their catheter. Now you need to be thinking they've got kidney involvement, right? So it can still be something that we need to assess and be aware of. All right? Localized flank and abdominal pain, of course, or palpable masses. Okay, signs and symptoms. Tenderness at the lower ribs or upper lumbar spine or the flank. Right? Everybody knows where your flank is? Yep. Pain can also be in the groin, shoulder, back, or flank. Okay? Ureter trauma, less than 2% of GU trauma, usually secondary to a penetrating trauma. Okay? Because it's such a kind of a free-flowing small structure. It's usually not going to be a huge target or have huge problems for blunt trauma. It's usually the bigger structures that get the brunt of it. Okay? Usually secondary to penetrating trauma, again. Indicators, wound to the lower back with urine that's escaping. Now, are you going to see that? Maybe. You know, is it mixed with the blood? Who knows? Okay? Did you have a question? No? Okay. Urinary bladder trauma. This is basically blunt blunt injury to the lower abdomen. You guys remember where your bladder sits? Right above your pelvic bone. Okay, real low. Okay, seat belts can cause it. Pelvic fractures, because remember, it almost sits down into your pelvis. So pelvic fractures don't necessarily, well, it can cause it because it can cause issues to the underlying structures. But again, remember, if I had significant enough force to cause that pelvic damage, what else is, that pelvic fracture, what else is damaged? What other structures are damaged? Okay? Penetrating trauma to the lower abdomen or to the perineum. Okay? I'm pregnant, it's not your baby. This will teach you, kind of thing. So you got to kind of base it on where is the injury, my level of suspicion. Urine in the umbilicus, anterior thigh, scrotum, intralingual canals, and peritoneum. So this is basically a ruptured bladder. Dysuria, difficulty or painful urination. Hematuria, again. Okay. Suprapubic tenderness. So when you go palpating on the abdomen, if they're really tender there, we should probably be suspecting that they got an injury. Okay. Swelling, redness, secondary tissue damage from the urine. Remember, acidic, waste-like stuff. It's going to cause some nasty problems. Intraperitoneal bladder rupture. Sorry, guys. Urgency to void, inability to void. You guys know what void is? Urinate. Difficulty or painful urination. Shock, and then abdominal distension. Okay. Urethral trauma. So sudden decelerations, bladder shears off the urethra. Okay, again, bladder may be more secured. Okay. And then straddle injuries. What kind of straddle injuries? What is a straddle injury? Could be the little girl who has an injury on her bicycle. Okay, I've seen a straddle injury of somebody who was stepping out of the bathtub and slipped and fell, and they straddled the bathtub when they fell. Okay, anything like that can cause significant injuries. Okay, urethral trauma, signs and symptoms: blood of the external meatus. Okay, so the external structures. Okay. Peritoneal bruising or scrotal hematoma. Hematoma. You know what hematoma is? Yeah, essentially it's bruising. Well, can occur to both external and internal reproductive systems. So external is more common, pain, intensive bleeding, etc. Okay. Internal, rarely injured. Your ovaries, for example, are kind of free-floating, small, harder to get. Okay. Treat like blunt or penetrating trauma of soft tissue anywhere else on the body, regardless of, how people may feel about it. So male genital trauma. Usually it is not life-threatening, okay, as much as people generally think, oh my God, my life is over. I promise it isn't. Okay. It can be very painful, and of course it's a great area of concern for your patient. Okay. Avulsion of skin of the penis or the scrotum. Basically, you're going to treat that like any other avulsion. You're going to cover it with a moist dressing. Okay. Complete amputation of penis. Treat it as any other amputated part. We actually had a guy who did it, and he did it twice to himself. The second time he mailed it to his ex-wife before he called for help to ensure that it could not be reattached. All right. Yeah. He took a circular saw and cut his abdomen open. Yeah. They are out there, folks. They are out there. Okay. Blunt trauma to the penis and scrotum. Obviously, apply ice. So, if you get racked, right? How many of you guys have been racked in here? Does that mean none of you? Oh, so that wasn't not me. That was a holy crap. All of us have. Okay. If you want ice, right? One once had a discussion with Chuck, who you guys know, right? Comes in, he's adjunct faculty here. And he's like, I give him pain medicine. I was like, what? Whatever. He's like, you don't even know. Give them something for pain. It hurts. So apply ice packs. Urethral foreign bodies. This does happen too. Okay. Don't remove the item. This is just like an impalement. Don't take it out. Okay. If penis in a zipper. How many of you guys have done this? Nobody? Okay. So, if there's only 1 or 2 teeth of the zipper involved, try to undo the zipper. Okay. Any more than that, cut the zipper out of the clothes, cover your patient, take him in. Okay? Right? Female genital trauma internally is rarely injured. External can cause pain, extensive bleeding, usually not life-threatening. The one that was getting out of the bathtub, there was a little more to it. It was a little girl when I worked at the Trauma Center for Pediatrics, and they had the sliding shower doors, so there was that metal rail that she fell on. We had to do some reconstruction there. She hurt. It caused intense pain, right? Why does this cause so much pain, guys and gals? Because it's right. It's supposed to have increased sensation. Okay. Again, usually not life-threatening. Treat with compresses and pressure. Now, sexual assault. Let's talk about that. Okay. So avoid examining the genitals unless they have extensive bleeding that you need to address. Okay. Ask the patient. Now this is difficult, right? Because you're asking someone, don't go to the bathroom, don't wipe, don't douche, don't take a shower, don't take a bath. And that's the first thing these ladies want to do. Or even guys. Okay? Even guys. That's the first thing they want to do, right? They feel very dirty. They feel violated. When they do that, they get rid of, a lot of the things that could tie them to their assaulter, if you will. Okay? Ask them not to change their clothes. Because, right, even I'm just going to change them. We'll take them with us. Even doing that, you're going to lose a lot. Okay? However, you need to kind of be understanding. And don't be like, you can't change your clothes. It's probably not going to get you very far. Okay? Record the history. Avoid extensive questions about the event. Okay? And you'll hear me talk a lot about, we wear many hats in this job. We're friends, we're counselors, we're, a lot of things. This is not something you need to get into if you don't have specialized training to do so. Okay? Questions? Take 5.